HIV/AIDS. So after the epidemic began in the 80s, since the beginning of the epidemic, and yes, the epidemic is ongoing, it is an ongoing epidemic, we consider it even 35 years later, up until 2013, because that's the latest data that I found on short notice, almost 78 million people have been infected with HIV, and about 39 million people have died of HIV globally. Now, according to the WHO, there were an estimated 35 million people living with HIV worldwide in 2015. So yes, the numbers do sort of work out, but with the error ranges. In the same year, in 2013, an estimated 1.5 million people with the error range died from HIV-related illnesses. Go. So, in the same year, an estimated 1.5 million people died from HIV and HIV-related illnesses. Now, mostly we are talking about HIV-related illnesses because, as we discussed, HIV does not necessarily kill in and of itself. Most of these deaths and HIV infections are occurring in Africa, Southeast Asia, and the Americas, in that order. Now, this is in CDC. This is a CDC graph from 2012 showing the estimated HIV incidence among adults and adolescents in the United States. There were an estimated 50,000 new HIV cases, an incidence in the United States of 50,000. And the incidence has actually remained fairly stable overall in recent years. And this is most likely as a result to improvements in heart therapy, as well as HAART being highly active antiretroviral therapy, HAART, in addition to improved education, as well as a number of other outreach programs. With overall estimates, however, there are disparities among who is affected by this disease. Primarily, we are referring to men who have sex with men. Those are the individuals who are the most likely to be at risk of contracting HIV. The largest groups with the highest incidence, the groups with the highest incidence are white, then black men who have sex with men, and then Hispanic and Latino men who have sex with men, followed by black heterosexual women, and then black heterosexual men. Then white heterosexual women, Hispanic and Latino, Hispanic and Latina heterosexual women, and then black male IV drug users are in last place. Now, this actually follows the nature of transmission of HIV. With unprotected anal sex with an HIV positive individual being the highest risk sexual behavior due to the nature of the mucosa in that region, and also the means by which HIV is transmitted and carried through seminal fluid, and when it is deposited onto mucosa, especially damaged and broken mucosa. And during sexual intercourse, anal and vaginal intercourse, the mucosa can be broken, and often is broken. Even during the course of consensual, normal sexual intercourse, the mucosa is broken. So, especially in unprotected sexual intercourse, when the seminal fluid is ejaculated onto the mucous membranes, that is when transmission is most likely to occur, because the viral particles are present inside that fluid, in high numbers. And remember that there is a long latency period in HIV. Times when people with HIV do not even know they have HIV. The initial symptoms, as you recall, of HIV are a long-lasting flu-like symptoms. Flu and muscle aches and fever that last for like 3 weeks, which is a long-lasting flu. It makes you very, very uncomfortable. You don't feel well. But you won't generally equate not feeling well for that length of time and those symptoms with unprotected sexual intercourse or IV drug use or whatever high-risk encounter you had with HIV-positive individuals, either fellow IV drug users or HIV-positive partners. Now, then there's that long latency period where you may experience no symptoms at all and you are still infectious. So because of that part, because of the nature there, because of the nature of the HIV virus, or rather HIV itself there, it becomes very difficult to contain and control the spread of this infection in that regard. So the best defense is simply to know your HIV status, to be tested every time you have a new partner. And then always to protect yourself. Always to protect yourself, even if you do know your status, and if you do know the status of your partner, because you don't know the status of your partner's partners if they have any. Now, back to the statistics here. This men who have sex with men issue, this is resultant not only from the means of transmission, but also a holdover from the original community in which HIV began in the United States, especially. Other countries around the world, it is not as high prevalence in the gay community, in the homosexual community, in the male homosexual community, as it is in the United States. In the United States, it started there through a series of unfortunate contacts and events. Now, because of that contact, it has persisted in that population, and this continued high incidence is a result of that. And we need to stamp out the stigma that HIV is a gay disease. It is not a gay disease. HIV is an everyone disease. It is transmitted through infected fluids, and it can be transmitted to everyone. Anyone is at risk. Everyone is at risk. So know your status. Now, these are the WHO regions that are affected. People estimated to be living with HIV, and this is the 2013 map, as I told you before. An estimated 35 million individuals with an error range of 33 to 37 million. And once again, the highest regions affected are Africa, Southeast Asia, and the Americas. Both North and South and Central America, all of them together, are grouped as one region. And the death rate follows exactly, the rate of adult and child deaths from AIDS follows exactly the same pattern. Because in order to die from HIV/AIDS, you have to have HIV/AIDS. And the death toll is 1.5 million on average, 1.4 to 1.7 range, error range. So the Mask of the Red Death was a story by Edgar Allan Poe. It was actually about tuberculosis. And tuberculosis is a pulmonary disease primarily. That is the one that we will be discussing for the most part. But it can affect many other tissues of the body, and we will discuss those briefly. But in pulmonary tuberculosis, in order for transmission to occur, the pathogen must enter the alveoli. However, if the infective dose of Mycobacterium tuberculosis, MTB, is only 10 bacteria, the same number of fingers you have on the standard hand, on the standard pair of hands, I should say. The standard hand has 5. On the standard pair of hands, you have 10 fingers, so 10 bacteria, that many. Not 10,000, not 10 million, 10. And which means that this low infective dose, if only 10 bacteria enter the alveoli, you now have tuberculosis. You are now infected with tuberculosis. That is all that is required in order to be infected with tuberculosis and to be sick. Now, it is spread through heavy droplets from the cough and sputum from an infected person. And people with prolonged, frequent, or close contact with people with TB are particularly high risk of becoming infected. There is an estimated 22% infection rate. So, a person with active but untreated tuberculosis may infect 10 to 15 or more people per year. That is not the same as the R0, which we will discuss later. That is per year. Tuberculosis is a chronic infectious disease. You remember the time courses that we discussed in Unit 5, Part 1, I believe is what we named that video. It is a chronic. The chronic time course indicates that you have the disease over a long period of time and it progresses slowly. Whereas an acute time course, you have the disease for a short period of time and it progresses quickly. And of course, you can have an acute on chronic, where you have a chronic disease and an acute problem, an acute exacerbation, where you get worse very quickly while having a chronic disease. So, tuberculosis is a chronic infectious disease. So is HIV. HIV is also a chronic infectious disease. Examples of an acute infectious disease, by the way, cholera, very acute. Symptoms develop quite rapidly. Symptoms also eject from you quite rapidly. Now, 10 to 15 people a year, and if you have active tuberculosis for a long period of time, that means that it's 10 to 15 more people, 10 to 15 or more people per year that you have it. You're coming into contact with a lot of people, 22% of the people you come in contact with. If 22% means you're only coming, if 22% of the people you come in contact with in a year is 10 to 15 people, you're not a very outgoing person. So do the math based on how outgoing you are. So transmission should occur only from people with active tuberculosis, because as we said, it's spread through heavy droplets from the cough and sputum. So the active form is when you should be coughing and producing sputum. The latent infection are not thought to be contagious because they are not coughing and producing sputum. So no cough, no sputum, no infectious nature of the disease. It is not infectious if you are not experiencing those symptoms because of how it is spread. So, latent tuberculosis is asymptomatic, and up to 25% of active pulmonary tuberculosis is also asymptomatic. Now, asymptomatic not in the sense of you don't have you may not have a cough and sputum production coming out of you, but you have an active pulmonary infection causing problems too deep in the lungs for the sputum to come out of you. That is also a possibility which we will discuss. Tuberculosis, the disease, should be suspected in persons who have the following symptoms. Unexplained weight loss. And we're not talking about the fluctuation of 5 pounds that you get from your water weight. Oh, I ate a big lunch today, so I'm about 2 pounds over my weight. No. We're talking about, I've lost 25 to 30 pounds this month, and I've been eating the same thing as usual. In fact, I've been eating more. No, that's either cancer or tuberculosis. Then you've got problems. Big problems. Loss of appetite. Night sweats. fever and fatigue. The night sweats are a big one. The night sweats are a big sign. And we're not talking about, oh, you just get a little warm, turn down the thermostat, you'll be fine. We're talking about the sheets are soaked through. You have a pool around you. You are sweating bullets through the night. If tuberculosis is in the lungs, if it is pulmonary tuberculosis, you may also have a cough that lasts longer than 3 weeks. At which point, if you have a cough that lasts longer than 3 weeks, you might want to get that checked out. That's the point where you say to yourself, okay, this just isn't a cough this isn't just a cough anymore. A cough that lasts less time, a short period of time, you may just have just a cough. I may just have an upper respiratory infection. It'll pass. 3 weeks, should have passed by now. Go get that checked out. Go get that checked out. Go pay somebody to go pay somebody to listen to your lungs. Go see your medical professional. Haemoptysis. Haemoptysis is coughing up blood. Coughing up blood. That's what they used to call the consumption. That's when you knew you were going to die of tuberculosis. Well, you knew you were going to die of tuberculosis. Quote unquote. Haemoptysis is coughing up blood. All that coughing that you are doing, it's not gentle coughing. This is rib flexing cough. This is lining of your lung tissues. This is lining of your lung tissue tearing cough. Torn tissues up in your lungs are causing you to bleed. The active infection that is going on down here is causing damage to your internal lung tissues and causing damage there, and you are losing blood through that. And so the sputum is also tinged with blood. So we're talking blood from damaged tissues here. Tissue damage blood. Chest pain, because damaged tissue hurts. TB could spread to other parts of the body through the bloodstream. If tuberculous disease is in other parts of the body, it is labeled as extrapulmonary tuberculosis. The symptoms are going to depend on the area that are affected. The most well documented are tuberculous lymphadenitis, where tuberculosis, the actual Mycobacterium tuberculosis bacterium, winds up in your lymph nodes. And you end up with big swollen lymph nodes where they infiltrate and grow very large. Tuberculous meningitis, where the actual bacterium is in your meninges, the lining that protects your brain and spinal cord. And it results in headache, neck pain, photophobia, fear of the light. Miliary tuberculosis. It looks like mill seeds. There's these little, y'all don't know what mill seeds are. This is the internet, look it up. Some of those are the most well-recognized manifestations. One that you hit a little close to home, Tuberculous Epididymitis. The epididymis is what connects your testicles to your penis. The urethra part of the penis. If that has become inflamed, it's going to hurt a lot, like being kicked in the nads consistently over a long period of time. Imagine that. Close your eyes and imagine that. All right. So, any part of the body can be affected by tuberculosis, but for unknown reasons, it very rarely affects the heart, the skeletal muscles, the pancreas, or the thyroid. It can, but it's very rare. It will very rarely affect those regions. So, if you effectively treat tuberculosis, then we can treat tuberculosis. We're okay. But if you do not treat tuberculosis effectively, the death rate for an active tuberculosis case is up to 66%. 2 in 3 chance you're dead. That's not a good chance. That is actually a very bad set of odds. You do not want those odds. The house will always win. on those odds. So about 90% of the infected have asymptomatic latent tuberculosis. And only 10% of those with latent tuberculosis are going to progress to active tuberculosis. So 10% will start with active tuberculosis. 10% of the 90% will convert from latent to active. But if you have HIV, back to HIV for a moment, where you are immunocompromised, where you are immunosuppressed, that risk of developing active tuberculosis from latent tuberculosis, it rises from 10% in a lifetime to 10% in a year. You do not like those odds. And if you don't properly treat it, death rate. Those odds are bad. And those odds are actually worse because you're immunocompromised too. So, TB infections begins when a mycobacterium reaches the pulmonary alveoli. We already said that. But we're going to talk now about, the antigenic concealment part, where tuberculosis, Mycobacterium tuberculosis, the bacterium, once it's in the alveoli, it's gotten past the wafting cilia of the pulmonary tissues, and it's gotten past all the sticky mucus from the goblet cells, and all the serous humidifying mucus from the glandular tissues. It's gotten past all of that. Now it's in the alveoli. Now it's the macrophage's job. In the lungs, we call them dust cells, but that's not Cambridge necessary. They're going to engulf tuberculosis because it's their job. Mycobacterium tuberculosis will be engulfed by macrophages because macrophages are good at their job and they're doing their job, engulfing whatever doesn't get cleared, whatever doesn't get cleared out and stuck to the mucus and removed by that protective layer, that first line of defense. These macrophages, in their second line of defense, their non-specific defense, are going to come up and try and engulf this mycobacterium, and they will succeed. They will engulf Mycobacterium tuberculosis. Unfortunately, macrophages are going to try and engulf by endocytosis, a type of endocytosis called phagocytosis. And in phagocytosis, they will extend cytoplasmic extensions around the bacterium, and then fuse those cytoplasmic extensions, creating a vesicle called a phagosome around this mycobacterium. Then this phagosome will be inside the macrophage. And then lysosomes will come up and fuse with the phagosome, creating a phagolysosome. Normally, the lysosome, as we discussed back in Unit 2, contains lytic enzymes and harsh chemical agents designed to destroy whatever it is that has been engulfed, to digest it and make it non-toxic to the cell. However, Mycobacterium tuberculosis has a capsule that contains within it a protein called mycolic acid. Mycolic acid prevents the actions of the lysosomal enzymes and chemicals from destroying the mycobacterium. Mycolic acid is protecting tuberculosis. So now, Mycobacterium tuberculosis has a nice little cottage inside of your macrophage, protected, concealed, where its surface antigens are concealed from your and the rest of your immune system. And because macrophages, which are normally antigen-presenting cells, cannot destroy this Mycobacterium tuberculosis in order to process it and present its antigens to T helper cells, or the rest of the specific immune system, for example, it's not going to present a strong, specific immune response. And Mycobacterium tuberculosis does not have any permanent immunity because of that. Because it is not presenting antigens. Because macrophages are not able to present antigens. So no immune response will be registered. Now, within the macrophage, the Mycobacterium tuberculosis bacterium is able to divide itself, multiply. And in its process of multiplication, it will expand, this new group of cells is going to pop that macrophage. It's going to kill those macrophages. And when it kills those macrophages, it's going to basically get macrophage goop everywhere. And it's going to incite a second line immune response, an inflammatory reaction from surrounding immune cells. And you're going to get an influx of a whole bunch of immune cells, and there's going to be a big battle waged there. And that's going to cause something called caseous necrosis. You're going to get a big necrotic lump inside that lung. And we'll talk more about that in a moment. But first, let's talk about estimated TB incidence rates. This isn't very good for raw numbers of incidents, but it is good to show where TB is mostly happening. We're looking at TB mostly in Africa, South Africa, and Southeast Asia. South Africa and Southeast Asia. Sub-Saharan and South Africa. This Greenland up here being really dark, Greenland doesn't have a very big population, and this is by numbers per 100,000. And if your population is small, you don't need very many people with tuberculosis to go green or go home. But here, there's an estimated 9.6 million new cases of tuberculosis per year as of 2014, with 1.1 million of those dying. 1.1 million of those dying from tuberculosis being HIV negative, and 0.39 million of those individuals dying being HIV positive. Now, we distinguish these numbers because tuberculosis, active tuberculosis, is one of our AIDS-defining illnesses. Our AIDS-defining illnesses. If you are HIV positive and you have active tuberculosis, you have AIDS. Because it is an opportunistic infection. But you do not have to have HIV in order to get tuberculosis. Tuberculosis can infect people just fine on its own. It does not need HIV to fight its battles for it. So, the incidence of 9.6 million and the mortality of 1.5-ish. A little less than that, maybe. Well, the variance range might be a little bit less to a little bit more. So primarily we're talking about Africa and Southeast Asia. And this is where the funding for antibiotic treatments for tuberculosis are scarce. It's very difficult to get medication in those regions. They are poorly served, especially in the poorest parts of those areas. South Africa may be a rich country, but that wealth is highly clustered, and the outlying regions have very poor parts. So Overall, though, in the last 25 years, we've seen a steady decline, or rather in the last 15 years, we've seen a steady decline in the incidence, prevalence, and mortality of tuberculosis. So we're getting a handle on things. We're getting things closer to under control. Now, this is a lovely image, but it's not available anymore free online, so I urge you to go and buy his book, Medcomics, www.medcomic.com. Shameless plug, I guess. No paid endorsement. This is not a paid endorsement. I'm not sponsored in any way. I'm just a fan. All right. So, tuberculosis, TB, Mycobacterium tuberculosis is a prokaryotic bacilli. Let's talk about the bacterium itself now. Graham's...
Right when you...
Okay. So, and right now. Gram stains, the property of mycolic acid, preventing them from gram staining even though they have a cell wall, makes them acid fast. They get rid of the acid fast. So they are acid fast bacilli because they are bacilli shaped organisms. Their shape is rod shaped. So they are bacilli. Instead of gram staining, in order to be able to see them on a microscopic slide, we have to use a series of stains to stain them bright red, usually like fuchsia or something like that. And that way we can identify tuberculosis from sputum samples. You actually have to take it from early morning sputum from a patient with tuberculosis or that you suspect has tuberculosis. So you get 3 consecutive early morning sputum samples and you microscopically examine them with acid-fast staining techniques to test for tuberculosis. Why early morning sputum? Because you produce sputum overnight and you're not coughing as much. So you have the most sputum in the morning. Makes sense, right? Sometimes sometimes the simplest answer is always right. Occam's razor. So, but this is not the only method of identification. There are also blood serology tests for tuberculosis, for the antibodies to tuberculosis, and there is the tuberculin skin test, the TST, also known as the purified protein derivative test, the PPD. It is a purified protein derivative of tuberculin. So, the incubation period of tuberculosis, from the time that you are exposed to those 10 individual bacteria is singular, bacteria is plural. From the time that you are exposed to those 10 bacteria to the time that you will have a positive reaction will be 2 to 12 weeks. That's not really the incubation period, I'm sorry. That is the lag time between exposure and antigen exposure or antigen challenge and primary response. My apologies. That is not incubation period. Incubation period is highly variable. My apologies. Incubation period is highly variable. It could be years, or it could be weeks. Depends on whether you start with active or start with latent. So the lag time before you have a positive PPD will be 2 to 12 weeks. The test will be ready to read within 48 to 72 hours after you are administered it. And you should be trained to read it. This is going to not certify you to read it, but this is how you read it. You read based on induration, the bump, not the redness surrounding the bump. The redness surrounding the bump is a red herring. The bump itself after 48 to 72 hours, after the initial swelling bump of when they injected the actual fluid is gone. Because that bump right there is from the injected fluid. That goes away. That flows out. But induration is a bump forms. A bunch of immune cells aggregate to that area to fight this tuberculin, this antigen. So, if it is greater than 5 millimeters in diameter, this lump, this induration, if the individual is HIV positive, or they've had recent contact with a person with active TB, or they have nodular or fibrotic changes on the chest X-ray, or they've had an organ transplant, which means they are immunosuppressed for purposes of not rejecting the transplant. If they are some form of either exposed to TB or immunocompromised, that is positive. You treat for TB. Or rather, you check for active TB, excuse me. You test for active TB. You do a chest X-ray to check for active TB. If it is greater than 10 millimeters of induration, if they are recently arrived from a different country where there is high prevalence of tuberculosis, less than 5 years ago, they are IV drug users, meaning they are at risk of HIV infection. They work in a setting where they are exposed to Mycobacterium. They have other comorbid conditions. They are under the age of 4. If they are exposed to people who are exposed to high-risk categories, 10 millimeters, you check for active TB. If it's greater than 15 millimeters, it doesn't matter what the risk factors are, that's a positive. You check for active TB. Once you've had a positive PPD skin test, a tuberculin skin test rather, once you've had a positive, it will always be positive because this is testing for an immune response to tuberculosis. And once you have had an immune response to tuberculosis, you will always have an immune response against tuberculosis. So once you've had a positive reaction, this test becomes moot. You know it's going to be positive in the future. You know that it will be positive in the future. You'll have to resort immediately to testing for active tuberculosis in the future. So this is what you do. A positive PPD, there's an area of redness around these two black lines. That's Sharpie marks. That's not part of the induration. Those are Sharpie marks. That induration is greater than 15 millimeters. I can't tell because there's no ruler there, but let's say it is. That plus a positive chest X-ray where you see nodular masses here and here, that's active tuberculosis. Active tuberculosis. This is a gone focus. That indicates that there are past fibrotic changes from tuberculosis. A great battle was waged here. Caseous necrosis occurred. So that right there, that's scar tissue right there. Versus normal. No scar tissue to be found here. So let's talk about some drugs used to treat tuberculosis. Tuberculosis has resistance to multiple antibiotics. And it has a tendency to mutate very quickly and develop resistance. It is a nasty little bug. It will become resistant at the drop of a hat. And resistance is a very dangerous problem. Basically, medications that we use to treat pathogens will become ineffective for treating those pathogens. That's what resistance means. They don't become immune. It's not the same thing. It just becomes more difficult to kill a pathogen with an antibiotic when they are resistant. It takes really high doses, or it takes additional medications to keep them from destroying it, or it takes a longer course of treatment. Whatever happens, they are harder to kill. That is resistance. They are not immune. They're just harder to kill. But that's a big problem in and of itself. So one of the things we'll talk about in more detail in the future is the vertical selection pressure. We'll talk about that in greater detail soon, so I won't mention it too greatly here. But when we treat tuberculosis, in order to prevent resistance, we treat with 5 different drugs. We'll talk about the 5-drug therapy. There are sometimes when we don't use the 5-drug therapy, but we'll talk about the 5-drug therapy. I called it Pyres when I was learning about it, but some people use Priest because ST is streptomycin. The T should probably be lowercase here because it's a bad acronym that way. But when you treat with 5 different antibiotics at once, even if tuberculosis is resistant to 3 of those 5, the other 2 will kill that resistant bug so that it can't grow back. So let's say that you have a mixture. You have 5 to the 5th power different bacteria in you. Each one is resistant to a different combination of these medications, 5 to the 4th power. So let's say that you have a bunch of different Mycobacterium tuberculosis strains. Each one is resistant to a different combination of these antibiotics. The ones that are resistant to the most antibiotics are going to die last. They're going to die the slowest. So it's important for people for people who are on treatment with all 5 medications to complete their entire course of antibiotics, because the most resistant strains die the slowest. You have to kill them all in order to keep any of them from growing back. And then if you killed the ones that are less resistant first, and the ones that are the most resistant are the only ones left, then when they grow back, you only have the most resistant ones. And they may have mutated new resistances to all 5. And then you are royally out of luck. So, Pyres, pyrazinamide, isoniazid, rifampin, ethambutol, and streptomycin. Priest also works where it's just a different order. It's pyrazinamide, rifampin, isoniazid, ethambutol, and then streptomycin, where they include the T as part of the name. Naming things is fun. So each one works in a different way, so that the mycobacterium would have to evolve an entirely different type of resistance in order to not die from it. If you use 2 drugs that have the same mechanism of action, then one evolution, one resistance, one means of resistance that evolved could work for 2 of those drugs. And you have essentially done your not working thing twice. You've done the same non-working solution twice. So there is a vaccine for tuberculosis. It is called the Bcg vaccine. It is okay to abbreviate BCG. It's the Bacille Calmette Guarin, and I'm pretty sure if I try and pronounce it, I will get it wrong or offend somebody, so not on YouTube. Because no one gets offended on the internet. It's not used in America, not routinely. It is not used in America routinely because it can give a false positive on the tuberculin skin test. And the tuberculin skin test is our first and cheapest means of testing for tuberculosis. And it is also not a particularly effective vaccine, and it, what's the word I'm looking for? Here in the United States, we don't have a lot of cases of tuberculosis to warrant routine vaccination with the Bcg vaccine. The fact that we don't have a lot of tuberculosis means that we don't have to vaccinate everyone against tuberculosis. It's not necessary. And the tuberculin skin test is cheap. It's only $40 a shot, I believe, last time I checked. I haven't checked in a while, to be perfectly honest. And so, because it makes you not able to use that test for the rest of that person's life, it's not a cost-effective measure to give the vaccine, and it's not cost-effective for the individual to be tested for tuberculosis ever again. Especially since they can still contract tuberculosis in the future if they are exposed. It's because it's only effective for children, not 100% for children. It's not very effective against the adult form of pulmonary tuberculosis. So now let's move on to talking about malaria. Malaria is a mosquito-borne infectious disease that is the result of infection by up to 5 separate parasitic protoctists. There's that word again, protoctists. Remember that you know how to spell it. Be sure that you know how to spell it. Of the Plasmodium genus. The individual species are not that useful to you, but I'll probably tell you them anyway. It's carried from person to person by female mosquitoes only, because only female mosquitoes drink blood. Male mosquitoes drink plant sap. This is just a life cycle thing. Females just need a blood meal in order to lay and fertilize and produce proper offspring. So, only female mosquitoes of the Anopheles genus, primarily the Gambier and Stevensi species, Gambier in Africa and Stevensi in India. When the mosquito takes blood from a malaria sufferer, that mosquito becomes a carrier of the parasite. The parasite itself does not kill the mosquito. Instead, the gametocytes that it siphons from the blood of the malaria sufferer, they mate inside the mosquito's gut and produce oocysts that become sporozoites that wend their way into the mosquito's salivary glands, that take root in the salivary glands. So now this mosquito is a carrier. Now when the mosquito lands on a new individual, because it is hungry once more, and bites that person in order to siphon off more blood so that they may produce their offspring, the saliva that gets injected carries with it Plasmodium sporozoites that mix with the uninfected individual's blood, and now that uninfected individual is exposed to Plasmodium sporozoites. They have now contracted malaria. They now have been exposed to the malarial pathogen, the protoctist, the parasite, the causative agent, whatever you wish to call it, those things are acceptable. Not disease. Do not call it disease. Do not call it germ. Parasite, protoctist, causative agent, Plasmodium sporozoites. So, malaria can also be transmitted in two other ways that are of note: from mother to baby, from mother to unborn baby, and also through blood transfusion. But these are more rare. Mosquitoes are the primary vector. And you remember that term, vector. Vector is the means through which a pathogen is spread. Now, this is the life cycle that is required of you for the Cambridge purposes. An infected mosquito, one that has the sporozoites in its saliva, in its salivary glands, bites a human being. The parasites will enter the blood. They will enter the liver and form a merozoa and form. They won't form a merozoite. They'll form a cyst inside the liver that I forget off the top of my head what it's called. Forgive me. But when that cyst ruptures from the liver cell, it releases merozoites into the bloodstream of the individual. And now that those merozoites are in the individual, they can continue their life cycle and be in various forms throughout that life cycle. And then when a new mosquito, infected or otherwise, comes along and bites that person, that infected individual, it now takes along with it the malarial parasite. And this is now an infected mosquito. It moves along and bites a new human. And the cycle continues. This is for your own edification. This is slightly more advanced life cycle, but it is not the full life cycle. The full life cycle is much more interesting. But you don't need to know that for Cambridge purposes. So, from the introduction of the sporozoites to the first appearance of symptoms, the incubation period, an average of 10 days to 4 weeks. However, you are dealing with 5 different species of Plasmodium. You have and there is a highly variable life cycle that involves multiple stages. So we're talking anywhere from 8 days to a year after exposure for symptoms to appear. This is a highly variable incubation period. But the average is 10 days to 4 weeks. The mainstay of malaria diagnosis has been microscopic examination of the blood. You take the blood out of the person, you put it on a glass slide, you put a cover slip on it, and you look at it. It is that simple. You look for evidence of the parasites inside the red blood cells. You look in the red blood cells. You can actually identify the species of Plasmodium by sight if you are a trained professional. And the species itself will actually help you in determining which drug treatment to use, especially because certain species are more resistant to certain antimalarial treatments than others. Now, if you're unsure, there are tests to detect the antigens in the blood, as well as PCR analysis to look for Plasmodium DNA. But in areas with few resources, which unfortunately goes hand in hand with endemic malaria, these really aren't as readily available as a blood film every 6 to 12 hours. And we say every 6 to 12 hours because you may not see any in the blood in the first slide or the second. So you keep checking because they're They crawl in. They're not in. They're in large numbers sometimes, but they're not in every blood sample every time. They're individual Plasmodium protoctists. So simply identifying a patient by sight, just saying, oh, they have a high fever and there's a lot of malaria here, we'll give them antimalarial treatment anyway. That happens a lot, but that usually leads to unnecessary treatment. But those numbers go down when you start adding additional symptoms of severe anemia to the picture. When you start looking for symptoms of severe anemia and you add those to the picture, the rates of unnecessary treatment go down. So these are some images of the plasmodial blood films. Falciparum, Vivax, Ovale, Malariae. I forget the fifth species. But there are multiple forms here. And if you see any of these, for your purposes, it's malaria. For your purposes, if you see any of these, it's malaria that you're dealing with. On the Cambridge exam, they're only going to test you on malaria. They won't test you on another disease that looks like it. They won't. It's malaria for your purposes. For Cambridge purposes, it's malaria. If you see any of these, okay? You don't need to know the life cycles. You need to know ring form, schizont, trophozoite. You don't need to know that. No. If it's in the blood and it's a thing if it's a thing with a ring or a bunch of nuclei in a red blood cell, which there should never be, then it's malaria. Now, the symptoms of malaria. The symptoms of malaria are caused by the release of merozoites into the bloodstream, or the anemia that comes after, that comes from them destroying the red blood cells after they come out of the red blood cells. So your typical ill symptoms are chills, fever, and sweating. You can also have headaches, muscle pains, nausea, vomiting. This is a direct result of the immune response to the parasite. The anemia, the symptoms of anemia are pallor, weakness, and fatigue. Pallor is paleness. It's because you have a lack of red blood cells. The red blood cells are red because of the oxygen-carrying hemoglobin. It's red because of the oxidation of iron in the heme. So large amounts of free hemoglobin are also going to cause you some problems. You can get jaundice, which is yellowing of the skin and the sclera of the eyes, the white parts of the eyes. That's due to excess bilirubin, which is a breakdown product of hemoglobin. Common symptoms, otherwise, are bloody stools, coma, and convulsions. Other signs that a healthcare worker might find with malaria experiencing patients. Low red blood cell count, that's the definition of anemia. Hepatomegaly or splenomegaly, and if you add those together, it's hepatosplenomegaly. You just add the prefixes together. That's an enlarged liver and an enlarged spleen. Hepato, liver. Spleno, spleen. And that comes from inflammation and hemolysis fragments getting trapped in those organs. Now, let's talk about medications. Quinine. Quinine was first isolated in 1820 chemically from the bark of the cinchona or cinchona tree. I'm not 100% certain on that pronunciation. But once again, Cambridge is reading your paper, not listening to a mixtape you made them. So it doesn't matter how you pronounce it, so long as you spell it right. The evidence suggests, however, that the bark has been used against malaria since at least 1632 that we know of. So it's on the WHO list of essential medications, meaning we can't have modern medicine without quinine. Modern medicine needs quinine. It's not first line for malaria because there's a lot of resistance to quinine amongst malaria species, amongst Plasmodium species, but it is a very good medication for malaria. Quinine is also the flavor component in tonic water. It's where the gin and tonic came from. So the wholesale price is about $1.70 to $3.40 per course of treatment. And if you get it in the U.S. from a pharmaceutical company, about $200. And it glows under a black light. Mr. Freeze in Batman and Robin's suit was black light quinine. Very cool. Anyway, this is the plant. Canada Dry. Not a sponsor, just a fan. Make sure if you're looking for the ginger ale that you get the green, not the yellow. The yellow is tonic. This is much more bitter. All right. Neat party trick, though. So, these are some of the drugs. Chloroquine, atovaquone proguanil, Malarone. That one is given a lot for prevention. When you're going to a malaria endemic area, people get Malarone a lot. Methylquine and quinine. Quinine now has to be used in combination with antibiotics, tetracycline antibiotics like doxycycline, or clindamycin, which is an aminoglycoside antibiotic, if I'm remembering correctly. I might be wrong. I'll have to look that up later. No one's ever wrong on the internet. So, I'm sure someone in the comments will tell me if this ever goes beyond our class. Quinidine. Quinidine is not the same as quinine. Do not make that mistake. Be sure that if you're talking about quinine, you're talking about quinine. Now, primaquine is also effective against the dormant parasite in the liver. So all of these are more active against the blood form of the parasite. Primaquine is active against the liver form. So remember, part of this life cycle includes a liver cyst, liver parasite. So if you clear the parasite in the blood, but you don't clear the parasite in the liver, and then more parasite exits from the liver cell into your blood, guess what? You have malaria again. The symptoms of malaria again. You have the infectious illness of malaria again. You treated it, it came back. Primaquine kills the stuff in the liver. However, you cannot give it to pregnant ladies. It will do bad things to that baby, that unborn baby. It will do very bad things. So, how you treat a patient with malaria, it depends on what they're infected with, what other sicknesses they have, whether they're pregnant or not, where they are going, where they are in the world, if they have any drug allergies. If they're allergic to tonic, don't give them quinine antibiotics. So, also the clinical status of the patient, by the way. If they are actively dying of circulatory shock, they have bigger problems than clearing the malarial parasite, like, replenishing their blood volume. So these are malaria endemic areas. This map is shaped like this. Unlike our previous maps, it is not country by country. It is shaped by areas. It is shaped by areas. And the reason it is shaped by areas is because it is based on the location of the Anopheles mosquito. It's based on the geographic distribution of mosquitoes, specifically that genus, the Anopheles. So mosquitoes lay their eggs in standing water, in swamps. In swamps, standing water, brackish, shallow water. And you can drain those swamps. In fact, back in the Renaissance, in Italy, they eradicated malaria in that area by draining the swamps. They had malaria in Italy at the time, and they drained the swamps and people stopped getting malaria. And they claimed that it was clearly that was because the noxious vapors from the swamp were no longer infecting people. The miasma was gone. No, it was not miasma. It was the mosquitoes. Yeah, malaria actually comes from the Italian for bad air, malaria. So, what do you know? So, draining swamps is not economically viable in areas where there aren't a lot of people. If you don't have a lot of people in an area, you don't drain the swamps. Draining the swamps is not economically feasible, and also the environmental impacts are a little bit problematic for most places. Mosquito nets help, but as soon as there is one hole in a mosquito net, it is drastically less effective, because a mosquito can get through a hole in a mosquito net, and one mosquito is all it takes. One infected mosquito is all it takes to give you malaria. Spraying insecticides everywhere to kill the mosquitoes helped. In fact, when we were spraying DDT everywhere, the numbers of malaria, the number of cases of malaria dropped significantly. Then DDT was banned worldwide and the mosquitoes came back. And now there are DDT-resistant strains of mosquitoes, so it will never work again. But you know, now we have now the eagles are coming back, so that's a plus. Their eggshells are strong enough. All right. Prevention. Prevention is key. There is no vaccine, or at least no effective vaccine at this time, but we know where malaria lives and how it spreads, so we can protect people who go to at-risk areas. People who live there, it's a little harder, but people who are going just to visit, we can protect. Individuals who have a repeated infection with the same species may develop a tolerance to that parasite over time, but as soon as they get infected with a different species, that tolerance doesn't hold, and they can die just like anybody else. And besides, if one of those times that they get infected with that species, if it kills them, their building up of tolerance to malaria does them no good. So, yeah, it's not a good long-term solution to just keep letting them get malaria. That's not a good plan. That's a bad plan. That's a really bad plan. So the medications that we use, like for example when I mentioned Malarone before, atovaquone, proguanil, those are used to prevent people from getting malaria when they go to an endemic malarial area. So this is actually not as useful as that map of where it is, so we're not going to talk about that. So according to the World Malaria Report in 2015, there were 214 million cases of malaria globally in 2015, with a pretty wide estimate variance range, 150 to 300 million. and 438,000 deaths, 236,000 to 635,000 deaths, representing a decrease in malaria cases and deaths since 2000. So good, yay. The heaviest burden is in Africa. Africa has the most malaria, and 90% of all malaria deaths occur in Africa, especially children under the age of 5. More than 2/3 of all of those 90% of deaths are children under the age of 5. So malaria is really, really bad. It's killing a lot of children. And globally, an estimated 3.2 billion people in 95 countries and territories are at risk of being infected with malaria. And 1.2 billion are at high risk. So of those 3.2 billion, 1.2 billion are at high risk, which means that in a year, a little more than 1 in 1,000 chance of getting malaria. And once again, if you get malaria once, you're not immune. You can get malaria again. You can get malaria multiple times. And yeah, you can die any of those times. Except until the last time. Did I lose the last time? All right, well, wait, just stop it. So there is a group that has resistance to malaria, sort of. It's not resistance to getting malaria, it's resistance to dying from malaria. So there's a population of individuals that have sickle cell disease, sickle cell anemia, the genetic disorder that we discussed earlier. It is an autosomal recessive genetic mutation, which means that you need 2 copies of the mutated gene, one from mom and one from dad, in order to have the disease. So an individual who has no mutated copies, they are homozygous wild type, or homozygous normal. Homozygous normal allele. They can get malaria just like everybody else, and they can die from malaria just like everybody else. That's this small blue line right here. Individuals who are homozygous HBS, homozygous for sickle cell anemia, they have sickle cell anemia. That's this red line right here. They are most at risk of dying from malaria because they get anemia from their own genetic disease. Their own blood is causing them to get anemia. And malaria causes really bad anemia. Anemia plus really equals really, 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 really bad anemia, which equals death in a lot of cases. So that's a really low, chance of survival, a really high mortality rate. But the heterozygous, which means they have 1 copy of the mutation and 1 normal copy of the allele. So 1 mutation, 1 normal copy. Heterozygous sickle cell. This is called sickle cell trait. Those individuals have a resistance to dying from malaria. They can contract malaria. They can be bitten by an Anopheles mosquito and have the sporozoites mix with their bloodstream. These sporozoites will enter their liver, and then the merozoites will be released from their liver into their bloodstream, and then they will enter their red cells, and all those things will occur. But the entry of the merozoite into the red blood cell is not as strong. That doesn't happen as often. There's something about that heterozygosity that makes that blood a little less attractive. It makes them a little less likely to die. The severity is decreased. So this pink line right here shows the survival rates. So survival rate for hemoglobin sickle cell, red line, very low. Blue line, normal alleles. That's the standard, that's the control. The pink line is slightly higher. There is an increased survival in in sickle cell trait individuals, heterozygous sickle cell trait. They don't have sickle cell disease. They don't have sickle cell anemia. And they don't die as readily from malaria. This is not immunity. They're getting malaria. They're just not dying as often. I think this is a decent place to stop the video because we're at the end of infectious diseases and we'll start antibiotics after.